Well, good evening, everyone. Thank you so much for joining us today for our MGH Fund lecture. And tonight we're going to be highlighting the Center for Global Health. We'll focus on the center's work before and throughout the COVID-19 pandemic and the role that global health plays in the current and future health crises, as well as how Mass General can and should be part of advancing global health equity. Now, for those of you who don't know me, I'm Dr. Brit Nicholson. I'm Senior Vice President for Development at Massachusetts General Hospital, and it really is my pleasure to serve as your MC for this evening's lecture. Now, before we get started, I have a few housekeeping reminders to share with you. Today's program is a webinar, so you do not need a microphone or video camera to participate, and no one can see you. Again, no one can see you. At any point during the webinar, you may ask questions anonymously if you prefer, and you can use the Q&A functionality at the bottom of your Zoom screen. Now, the webinar will also be recorded, and a shareable link to that recording will be provided after the event. So with that, I'd like to give a special welcome today to our MGH Fund donors. I can't tell you how grateful we are to you for your commitment to Mass General, and your unrestricted support for the hospital makes it possible for us to reach our goals to transform patient care, break new ground in research, trailblaze in medical education, and really point to building healthier communities, not only here in New England, but around the world. We're so grateful to our donors for their dedication to Mass General and for the flexible support you provide that allows us not only to really meet the challenges that faces, but also to really provide funding for those opportunities that come our way. I'd also like to welcome members of our hospital's Phillips Society. Now, the Phillips Society honors and recognizes those who's designated the hospital as a philanthropic priority through their bequest intention, charitable gift annuity, charitable trust, endowed fund, or any other legacy gift. And your generous and forward-thinking philanthropic commitments will provide future support to the hospital. Now, as many of you may know, we celebrated Mass General's 200th anniversary of admitting our first patient. Our 200th anniversary for the establishment of the hospital occurred in 1811, but it took 10 years to build the hospital, and we admitted our first patient on September 1st, 1821, a New York resident, a 30-year-old saddle maker suffering from the brutal effects of syphilis. The saddle maker entered the doors of Boston's brand new and first hospital. And this single patient admission inaugurated a tradition of the pursuit of excellence that for 2 centuries has shaped the practice of medicine and healthcare in this city and around the world. And philanthropy has always been a strong tradition at Mass General. According to the West End Museum, after the hospital received its charter, an early fundraising campaign brought physicians and citizens together, as well as local philanthropists of the day who made gifts of varying amounts, including, at one point, a 600-pound sow, an in-kind gift, which perhaps equates to maybe a few shares of Amazon stock today. Again, our donors have always been generous. Now, as many of you know, we welcomed a new hospital president this last month, Dr. David Brown, and we couldn't be more excited. Some of you may know David already. In his 3 decades at Mass General, he's established himself as an outstanding, visionary, and collaborative clinician, educator, and leader. In addition to his many clinical, academic, and administrative successes, David has already proven himself to be an enthusiastic partner in our fundraising initiatives. And I know he'll enjoy becoming acquainted with all of you over the months ahead. And he asked me specifically to share his regrets that he wasn't able to join us tonight, but he'd also like you to know that he's grateful for your support of the hospital. And I wouldn't want this time to pass without once again recognizing Dr. Peter Slavin, our former president, who was an extraordinary leader whose vision, compassion, his thoughtful approach, including his commitment to increasing the equity and inclusivity of the care we provide for our patient communities, strengthen the hospital, and position us for a very bright future. We're grateful to Peter for his many services to Mass General. Now, as many of you may be aware, we publicly launched our largest ever fundraising effort, the Campaign for Mass General, this month. We have a campaign goal of raising $3 billion. The support of our donors at all levels will fuel our unrelenting pursuit of medical excellence, empowering patients, strengthening communities, and creating a healthier world. And it's absolutely the right time for this undertaking. We're living through a global pandemic, the likes of which I say the world has never seen. And Mass General has been at the forefront in developing clinical approaches to the care of COVID-19 patients. We've been at the forefront of the research that has helped with vaccine and therapy development, as well as the education of the next generation of caregivers here in New England and around the world about the ever-evolving best practices in COVID-19 patient care and the global pandemic response. And this is why it's my pleasure to welcome you today for a conversation about Mass General's global view of health. Since our founding, Mass General has been driven by the belief that everyone, everywhere, has a right to good health. And today, Mass General's Center for Global Health advances that mission in numerous ways. And thanks to your generous support, the center's strategic plan will receive MGH Fund support for the next 3 years. Our talk today will be with the center's executive director, Dr. Louise Ivers. Dr. Ivers is an associate professor of global health and social medicine and an associate professor of medicine at Harvard Medical School, as well as being an associate physician in the Division of Infectious Diseases here at the hospital and an associate physician in the Division of Global Health Equity at Brigham and Women's Hospital. As if that weren't enough, she's also serving as the interim chief of the Division of Infectious Diseases here at Mass General. Today, Dr. Ivers will focus on the work of the Center for Global Health before and throughout the COVID-19 pandemic. She'll unveil the role of global health and not only this current crisis, but future health crisis, as well as how Mass General can and should be part of advancing global health equity. Now, when Dr. Ivers finishes her presentation, you'll have about 15 minutes for a question and answer session. And you may submit your questions for Dr. Ivers during that session, again, using the Q&A feature. So now it's my pleasure to turn the program over to Dr. Ivers.
Great. Thank you so much. Can I just check now that you can see my slides and you can hear me okay? Get a thumbs up. Great. Good evening, everyone. Thank you so much, Dr. Nicholson, for inviting me to speak. And thanks to all of you for your attention and your support of the MGH Fund. My name is Louise Ivers, and I'm really thrilled that the MGH Fund has been applied to support us in the Center for Global Health for 3 years to help accelerate our activities. And I'd like to thank all of you for your contributions to that. What I'd like to do this evening is talk to you about what global health means in 2021, present to you why MGH should be doing this work, really the case for doing global health work at MGH, and some of the how, our strategy for doing this work and what we've been doing this past year and a half, thanks to our generous donors and thanks to the support of the MGH Fund. But first, I want to give you a little bit of a sense of myself that might help you to understand some of my passions in this area, and as an example of some of the kind of work that MGH supports. So in 2003, at the height of the AIDS crisis, I was encouraged by my mentors at Mass General Hospital to follow my passions and to bring my skill as a newly trained infectious diseases specialist to Haiti, to respond there to pandemics like HIV, tuberculosis, and later a massive cholera epidemic. I worked on building health systems and primary and secondary levels of care, and I learned so much I spent almost 12 years working between Haiti and Boston. I took care of patients in Boston and in hospitals in central Haiti, going back and forth. And I was really bringing the lessons from each place back to the other place. And the work in Haiti was and still is very challenging. I was working in a very rural place. We had serious challenges in infrastructure, but I had an absolutely fantastic team of Haitian colleagues to work side by side with. They're smart, they're dedicated, they're committed, and they taught me really everything I know about global health. I was in Haiti then in 2010 when a major earthquake occurred, and I spent the next 2 years working on that disaster response. And although to many people this kind of work seems charitable, I didn't and I don't consider that work as simply charity, and neither did the army of Haitians that I was collaborating with. I considered it as an extension of a mission to advance quality healthcare in a way that is perfectly suited to an academic medical center. It's perfectly suited to Mass General's mission. To me, it is academic medicine to engage in global solidarity through global health work and to bring the knowledge, resources, and opportunities from the most well-resourced places on the planet to the poorest places on the planet. I knew that if we could advance health in Haiti, we could do it anywhere. And what I learned in Haiti from Haitian community health workers, Haitian doctors, Haitian nurses, and leaders could transform how I thought about healthcare anywhere. And my years of training at MGH had taught me how to deliver compassionate care. This message was inscribed on the wall of the hospital when I came in every day. But Mass General also taught me how to leverage my experience of caring for patients and caring about patients into being part of bold breakthroughs and revolutionary results. And in the context of Haiti, this meant that while contributing to caring for patients, these are cholera cots in a cholera outbreak, my team and I felt emboldened that we could and we should be part of revolutionizing the care of the patient. And that my job was not just to take care of some of the poorest people in the world, but to learn what they needed, to listen to them, to work with them, and through that inquiry, to be led to answers, like not just how to reduce suffering from cholera by caring for patients in a crisis, but by how to eliminate cholera from the whole country. And our team, our binational team, made bold discoveries like how to apply cholera vaccines to control the pandemic, publishing high impact research together that's influenced the World Health Organization's approach to cholera. And we're now on a path, after 800,000 cases of cholera and 10,000 deaths of cholera in Haiti, to this revolutionary idea that we had to eliminate cholera from the whole country, despite the many other challenges. You might be familiar with the words of Drs. Jackson and Warren in the pictures here, when they wrote a letter calling for the founding of a hospital in Boston. When in distress, every man is our neighbor. And we often echo these words in a time of crisis as our rally call for global health. But I really believe that there's other parts of this letter are also very important in our global health work. And this is where it says, we have then to inquire into the situation of the poor in sickness and to learn what are their wants. For the Center for Global Health, with the support of the MGH Fund, global health is not only a term that encompasses compassionate care, because we do that. In Texas, this is after a hurricane disaster. In Mexico right now, a team on the border working with displaced persons. In the Bahamas after a hurricane. In Haiti after the recent earthquake in August. And in Uganda, in this COVID-19 treatment ward that we built with our Ugandan colleagues. But global health is more than that. Global health is a quest for health equity, and it leverages every possibility of academic medicine. It allows us the privilege of working upfront with communities. It offers us frameworks to inquire of their problems, and it seeds partnerships that grow and become intertwined, catalyzing science through our combined skill sets, combined knowledge, and combined talents. And it seeks solutions that are replicable and scalable. Global health is building partnerships and relationships, and global health is going back to the same partners who you worked with on cholera and supporting them, like here in the National Laboratory in Haiti, where we worked to give them reagents for COVID-19 testing this year. So Haitians themselves can determine how much exposure to COVID-19 there has really been in their country, where there's a remarkably low rate of vaccinations. And global health is also knowing that from their knowledge and their discoveries, we will learn. Global health is about teaching pathology, but also learning about tropical diseases. And global health is co-designing a nursing curriculum. Here are graduating nurses on the right, teaching it in Uganda 1 year and then teaching it across Zoom the next year in a pandemic. So why should MGH be doing this work though? I'm sometimes asked. Well, this is a picture on the left of my patient's home. And so it's not too hard to explain the emotional and the moral need to do this work. So I won't belabor this point, but I will present some of these other reasons for the case for MGH to do this. Half of the world's population is living on less than $2 a day. 65 million people are refugees or displaced. Only 5% of the world's population is vaccinated against COVID-19. There's a huge crisis in human resources for health around the world, and there's really insufficient surveillance of emerging diseases. We're seeing the impact of that right now in the pandemic. And really, there's a lot of suffering in the world that is truly needless. And what I know from 2 decades of living and working all over the globe is that talent is equally distributed around the world. And so is knowledge in its quantity, but it might be very different in its type. And so this creates what I think is an opportunity gap. And we have a maldistribution of resources and power in the world. And if we could just bring together the knowledge of diverse groups of very smart, talented people across the globe, we really could catalyze tremendous learning and innovation and discovery and change. And not many organizations are in a position to do that. Not many organizations have a platform that can do that for the advancement of clinical care and health science and health equity. And bringing that knowledge together is a huge potential opportunity for us in global health. Mass General Hospital is in a great position to harness that opportunity through thoughtful programs and a careful approach that leads to discoveries that ultimately benefit us all. So let's take a look, for example, at COVID-19 and the response. On the top left here is a COVID testing booth in South Korea that our colleagues in the Center for Global Health worked to translate into a very similar COVID testing booth that we used at Mass General and still use at Mass General, and has saved hundreds of thousands of dollars in personal protective equipment and kept our staff safe as they were testing. We learned a lot about contact tracing from Africa. We did contact tracing in Haiti for a long time. We learned from a lot of our colleagues doing contact tracing on Ebola. We brought those lessons from those experiences to the US, and contact tracing has been a very important part of our COVID-19 pandemic response. In July, I traveled to Haiti to participate in caring for patients with COVID-19, and these are some of my colleagues. This year, also thanks to the MGH Fund, we have deployed clinical teams to care for patients with COVID in Mexico, in South Dakota, in the Navajo Nation, in Uganda, and this deployment in Haiti. Our teams have also worked with our global partners on research studies that range from COVID-19 testing approaches to disparities in COVID-19 outcomes, studying variants that are circulating, and currently working a lot on trying to address COVID vaccine inequity. What we see at Mass General is that global health interest is only growing amongst our faculty and our trainees. This year, thanks to the MGH Fund, we were able to accelerate programs that we had planned in our strategic planning work. Those include global programs in palliative care, in cancer care, and also in gastroenterology. Really exciting times, despite the chaos of the world, that we're able to make these steps forward. But sometimes people ask me, are we just a drop in the ocean? Because the problems seem overwhelming. But I always answer that the answer is no. We're not just a drop in the ocean. Global health work is reciprocal. We are providing service to the poorest communities around the world, but we are truly advancing scientific discovery. And this work is very enriching to our MGH community. We are also working on solvable problems. We're working on problems like needless deaths, unnecessary suffering. We're tackling big issues, but that's what MGH is good at, tackling big issues and approaching them from a variety of perspectives, bringing care, bringing breakthroughs, and delivering results. Our approach to this work is to create a global network of knowledgeable, skillful clinicians, scientists, and educators, and we partner across the world and across the country with diverse communities. We work within MGH to collaborate, to accelerate, to mentor amongst faculty and trainees who are positioned in various departments and institutes and centers across the hospital. That's enduring work. That is impactful work. This is a training day photo. I gave a quick show of it earlier, but it's from 2003, where I taught HIV treatment protocols to Haitian colleagues. But I learned from them that day and for subsequent 18 years about the social determinants of health and how to address them and how to deliver care in pandemics and deliver care in very complex environments. Since 2003, all of my Haitian colleagues in this photograph have gone on to lead. Most of them are still living and working in Haiti. Some of them are leading programs in Africa for the organization Partners in Health. Some of them are working for the US government in Haiti, advancing the mission of CDC and US aid. When we do this work right, it really has enduring power. I'd like to share a quote from one member of our global health community. We hope to be the next generation of clinician scientists and drive health forward in South Africa. Professor Maswime is an OBGYN surgeon from South Africa who came to Mass General for 1 year for a fellowship for research and mentorship. At the end of her year, she was recruited back to be the head of global surgery at the University of Cape Town in South Africa, and she has been absolutely blazing a path since that time. I cannot keep up with this amazing woman. She presented at the World Economic Forum. She's become the associate editor of the South African Journal of Obstetrics and Gynecology. She's president of the South African Clinician Scientist Society. She's really contributing to changing the way that the surgical practice is actually taught in Africa and making big strides forward. Philanthropy really has been and can continue to be transformative for our work. Our patients are never asked to pay for their care. Philanthropy allows us to care for the poorest people. It allows us to invest in talent. It allows us to build research capacity and to build partnerships that create that enduring impact that we're seeking. We're very, very grateful to our supporters and our partners in this work. The MGH Fund has really allowed us to continue to thrive and to grow our reach during the very chaotic 18 months of this pandemic. We had just completed our 5-year strategic plan before the first cases arrived in Boston, and this plan encompasses a 5-tiered strategy. It has continued to guide our way despite the uncertainty and the challenges of the pandemic. We have programs that are focused in research and innovation. We have a global nursing program whose goal is to empower the nurse in the healthcare setting and to train the next generation of global nurses. We have a program that is heavily integrated with partnerships. Those are the partnerships we have within MGH and the partnerships that we have and we seek to ensure are long-term in the global settings, especially in Uganda, but also in Bangladesh, in Haiti, and in other countries that are beginning to be increased as we go forward. We are an institution that is renowned for its medical education and teaching, and we embrace this and train the next generation of global health leaders who are both based here, but also who come here for periods of time, like Professor Maswime did. And finally, we have a humanitarian action arm. And this is the arm of our work that deploys. We deploy in emergencies, we deploy in crises to go to work side by side with our clinician colleagues overseas or domestically outside of New England when there's a disaster. We have very, very big goals, but we have an amazing team of faculty and staff to do that with. So on behalf of all of them, I would like to thank all of you, and I'll be welcome to pass the microphone back to Dr. Nicholson for the next session to answer any questions.
Dr. Ivers, thanks very much. And the questions, not surprisingly, are beginning to come in. I think the first one is, do you think COVID has overshadowed other areas of healthcare globally that we need to focus on? And if so, what do you think those areas are?
That's a really great question. We've seen that COVID has really crowded out healthcare, even in the US. In April of 2020, some 40% of respondents in a survey had reported in the US that they had not attended for urgent care issues that they thought were urgent, so they had deferred them. And when you dive deeper into that survey, it was not equally distributed. So the people who were least likely to come for care were actually probably the people who most needed it. So I think what we will see when we get the data from the global setting is something very similar. In 2014, there was a very large Ebola virus disease outbreak in West Africa, and there were about 28,000 cases over the 2 years. During that time, there was an estimate that 4,000 women died due to being unable to access a safe place to give birth. So there was 4,000 additional maternal deaths, and there was reported to be about 10,000 additional malaria cases in children. So that's documented. So I expect that we will see that usual care in many places around the world is displaced. And sometimes the most fragile places where we see that showing up is actually around, especially maternal health, where maternal mortality can go up, but also in the management of chronic disease like HIV or diabetes, where people may not be able to come and get their medications or see their doctors routinely. So I do expect it to be a concern.
So from what you've seen in your work and your travels, this is actually a two-part question. What is one of the largest impacts COVID has had globally in countries outside of the US, especially those that may not have easy access to vaccines and healthcare? And the second part is, you mentioned a figure of under-resourced areas that only 5% of the population had been vaccinated. And do you think that this is going to ensure the life of the pandemic for years to come?
Yes, so I think outside the US, many places like Europe had very similar outbreaks to ours, although with substantial differences, but generally speaking. In other countries, we've seen a lot of differences, which just highlights, I think, the heterogeneity of countries and problems and issues and public health systems and trust in government, et cetera. I can speak to a couple of the places where I work and have been in close contact. We saw in India, a huge surge of COVID with really dramatic, was in the news for quite some time, really dramatic mortality and challenges on their healthcare system. We've seen in Uganda a couple of waves of COVID-19 that have been really devastating. We lost 3 of our colleagues this year in Uganda. 2 of them were related to COVID-19, unfortunately. We're seeing healthcare workers really, really impacted because they don't have the vaccine, but they also don't have the personal protective equipment that we have the privilege of having in our hospital, and they don't have the healthcare infrastructure that can really ensure the airflow is flowing correctly to protect the healthcare workers, and they don't have the oxygen infrastructure. So I think we've seen very different outbreaks in very different countries, but in all the countries and all the colleagues that I have, COVID-19 has been a huge concern and a huge impact. In countries like Uganda, for example, early on, there was a very, very, very intense lockdown. People were really at home and ordered to be at home. And this, in a more fragile economy, had huge impacts on the livelihoods of the poorest people. We saw the impact on the economy in our own situation with that. So imagine when that is amplified in a poorer situation. I think your second question about vaccine equity, we should not expect to really see this pandemic truly under control until we have access to the vaccine for all people. We will certainly see a period of time, I think, in which we are able to see reduction in numbers in our own communities. Certainly in Massachusetts, we have a high vaccination uptake rate. Soon children will be able to be vaccinated, and we might have a reprieve. I hope we have a reprieve. However, the circulation of new variants is definitely something to be of concern from a public health and epidemiology perspective. The Delta variant, which we're all very familiar with now, and created huge surges of cases in almost every country, originated in a subcontinent in India, where they didn't have access to vaccination. So I think we have to be prepared for the fact that the virus is very pernicious, and there's a reasonable likelihood of variants of concern emerging in the future if we don't vaccinate the whole world. Plus, it's also just not right that we can't have the vaccine. But from a public health perspective and an epidemiology perspective, which I think is also what you were asking about, it's definitely a worry.
You had a very telling graphic where you effectively made the case that talent is equally distributed, but resources and power may not be. Do you have examples of things that you feel that we have learned from areas or countries that we have gone to? And so, for instance, a specific question came in when you were in Haiti. Did you learn of any healing methods with herbs or other gifts from nature in Haiti that appeared to work? So.
That's a great question. I think there are many, many lessons that we learn. In particular, from the medicinal side, I don't have examples from Haiti, but there are certainly examples around the world from that. One of our best medicines now for the treatment of malaria actually was used in traditional medicine in Asia for centuries or maybe even longer. So there are definitely scientific discoveries. There is traditional knowledge, there is oral tradition knowledge, there are things that certainly can translate into scientific discovery. I think that in many of the countries where I work outside the US, public health is a much more understood entity. I think in the US, what I saw is when we started talking about contact tracing for COVID-19, most Americans were like, what? What's this? Who's this calling me? But in my experience in public health in many other countries, there's a much more robust connection between the public and the work of public health. And the public are actually much more used to mass vaccination campaigns. They're used to a series of messages, and they're more familiar with the structures. I think that we learned a lot about what we might have done on contact tracing. If we had in the US, for example, done contact tracing to the extent that my Ugandan colleagues did it, and then we swooped in with vaccines in the US, we might have had a much smaller epidemic. In Uganda, what happened is they were excellent on contact tracing. And actually, they have a lot of experience from Ebola. They do contact tracing if they ever have an Ebola case. But what they didn't have was the swooping in with the vaccines. So I think there are many examples of things that we learn that we bring back. Another might be about integrated multidisciplinary care. Just last week, our lead doctors on palliative care, global palliative care here at Mass General, were telling me that when they work with their partners overseas, they're often really leaning more into the nursing staff and asking the nursing staff to take on a lot of responsibilities, and that had inspired them when they came back to MGH on their team to really think about how they assigned different tasks and how they could leverage more the leadership and the knowledge of their nursing colleagues. So I think there's kind of endless examples that I could cite where we can learn, but we do have to be willing to learn. And that's a humility factor that I like to show that slide about talent, because when we think about global health, we often think about it something that's here that we give out. But really, those of us engaged in it can see very quickly that when it's done right, it's really an exchange, and we get in different ways so much, at least the same, if not more, than what we give in the dialogue and the science.
It's clear from your talk that you've really had a long career in global health. You've been in challenging areas, and yet you're remarkably optimistic and enthusiastic about this. What are some of the experiences that give you that sense of optimism, and can you describe some of the things that you feel best about in terms of what you or your colleagues have been able to achieve during your career?
Well, I think that, thanks for that. I mean, I think that honestly, the choice is optimism and hope and finding a way forward, or being paralyzed by being overwhelmed. And, you know, being paralyzed by the overwhelming challenges, whether it's in Haiti or Uganda or just looking around the globe, is a luxury. And I have the luxury to just say, this is too hard, so I'm going to do something else. But the people who really inspire me to stay positive and kind of keep moving forward are those colleagues. Those colleagues in Haiti, where I show the picture, they're taking care of COVID patients in their COVID intensive care unit without half of the equipment or supplies that we have. And yet their lead physician was trained in Europe in intensive care. She knows what she's missing, you know, and yet every day for 12 hours a day, she was getting up and going in there. And so for me, the idea of not being optimistic when she's there pushing forward, I think it's not really a choice. I would say when I look at that photograph of my friends from now almost 20 years ago, 18 years ago, and my fresh face and, you know, in Haiti, and when I think about how far we have come together and how much I learned from them and they learned from us, and there's a system in Haiti now for taking care of patients with HIV, people who I trained and taught, those Haitians lead those conversations. They're ahead of me in knowing what's the right HIV medicine to use in their public health system. They totally took on ownership and leadership of that program. We started with no patients on the treatment for AIDS back in 2003, or just a handful. And we brought it up to 18,000 people living with HIV in Haiti, fully on their treatment, just in our programs, led by Haitians. That to me is a really great example of what's possible to do. In Uganda, we've had a very long partnership, Mass General Hospital and a regional referral hospital in Southwest Uganda. The longevity of that partnership has really helped us in the pandemic when we couldn't physically go there for a long time. Having a partner that you work with over 10 years and build trust and build relationships that you can count on each other in a crisis, that for me is also cause for optimism, because when we are deeply committed to this work, as MGH is, you can actually make those connections for the long term. And you know that even if you couldn't go for a year because of COVID, you're going to be there. It's just a matter of time, and it's just a matter of when, and you can do a lot remotely when you already have a partnership with people.
So Dr. Ivers, I love seeing the picture of the nursing graduation in Uganda, but I've heard that there's a global nursing shortage. What do you think is causing this, and how can it be rectified, and how can we attract people to nursing careers?
Yeah, that's a great question as well. So most of the care given around the world in healthcare is provided by nurses and nursing staff. But we, you know, the doctors, we like the microphone, and we often get the microphone. And I'm sure that whispering in my ear is my director of global nursing at MGH, Mary Siebert, and she's saying, like, don't forget the nurses. So I'm glad you asked that question. So there's a multitude of reasons why there's a nursing shortage. And one of it is quite simply that many poorer countries don't have a budget that allows them to hire the staff that they need. And because they can't pay staff even reasonable amounts of salary, they get a brain drain. So you have nurses who work, instead of in the public sector, they might choose to work in the private sector, in private clinics, or for non-governmental organizations that pay higher salaries. Or you get nurses who actually leave the country of their origin to go to work in other countries where there is better opportunities, or there are better opportunities. Even in my own country where I'm from, in Ireland, we drain a lot of nursing staff from Southeast Asia because we need to recruit nurses. So we draw them in, and then often that leaves behind. So when people talk about the human resources for health crisis, they are talking about doctors, but they're often really talking about nurses. And as I say, some of the factors are push factors, like people feel pushed out of the role because it's underpaid or undervalued. And some are pull factors, so they're pulled into other places where the opportunities are better. Our global nursing team has worked in Mbarara, Uganda now for 10 years and really helped to establish many fantastic initiatives there that they have described as really helping to empower their colleagues' voices, even in the care of the patient. So what I'll often find on the wards in Uganda is that the nurse's voice is not really listened to as a treatment and care partner, but in a more hierarchical way, which I think we did away with a long time ago in the US. And so the shared decision-making doesn't really happen. So that is one of the things that our nursing colleagues here at MGH have been working on in Uganda, to build their knowledge base through curriculum and master's programs, but also to build their leadership voice, allowing them to stand up for what they should, for what they want in the care of the patient. So that's been exciting to see too.
So when providing aid in a foreign country, especially during a rapidly evolving crisis, how does the Center for Global Health mobilize so quickly and effectively to collaborate with local hospitals and clinicians on the ground?
Great. So we have a couple of ways that we approach this. One is on the staffing side. We have a roster of volunteer doctors, nurses, pharmacists, physical therapists, translators. A lot of the diversity of MGH staffing and faculty participate in this volunteer roster. They train, they onboard, they're kind of ready to go if a disaster strikes. And we have a leadership team led by nurse practitioner, Lindsay Martin, who is constantly checking the roster, getting people up to speed. And then Lindsay is also connected in to the Pan American Health Organization Emergency Medical Technician Team. That's the EMT team. So the Pan American Health Organization is the branch of the World Health Organization, the WHO, that concerns itself with the Americas. And most of the time, the disasters we respond to, or the crises we respond to, are in the Americas. So Lindsay and her colleagues at the Pan American Health Organization are in regular contact. We are registered with them as an emergency deployment team. And if a crisis strikes, they will ask us for help if the government of the country asks them, and then we will send out a call for a team who might be available to go. So that is one of the approaches. The second approach that we really leaned on this year was longer term partnerships that we already had built. So I mentioned that we sent a team to Haiti. We also sent a team to Uganda, where we have longer term partnerships. And then this past 2 years, we've developed a relationship with an organization that works on the Mexico side of the Texas-Mexico border with displaced persons who are seeking asylum in the US. And so we were able to lean on that long-term partnership. So some of it is emergency, let's go now, new thing. And some of it is really working in the background, trying to establish the connections, because when the crisis hits, it can be somewhat chaotic. So we want to minimize that chaos and have as much ready to go as we can. And then we have these phenomenal doctors, nurses, pharmacists that I mentioned, and I mentioned a translator has gone to, who are willing to go for 2, 3, 4 weeks at a time from Mass General at the drop of a hat, leave their families. We have their managers on the ward and their colleagues on the ward who say, well, I'll cover for you, I'll make it work, you go. And I think there's a lot of satisfaction from the team who stay behind too, that they're helping this person go and respond to a crisis. So overall, it's a well planned out, but sometimes hectic time when that happens.
So in a post-pandemic era, and we all have our fingers crossed that there will be a post-pandemic era, what are the key lessons you've learned during COVID-19 that you think will change the way we think about global health?
I hope that I hope one of the lessons that the general public and the leaders of our nations maybe could draw from the situation is that we're really not safe until everyone is safe. Like, we really can't have health in a vacuum without the rest of the world. And this is just one pandemic. It's certainly not the first, and pandemics are happening in increasing frequency. So I think we have to look at this pandemic as a potential harbinger of what might happen in the future and see if we can, plan for that. For me, really, everything I knew about global health was just amplified in this pandemic. Honestly, how pandemics are never equally applied. Like, we talk about how the virus knows no difference, but the virus doesn't land into an equal playing field. Like, the virus comes into a social context in which some people have access, some people don't have access, some people are more exposed and other people are less exposed. And this means that we're going to have disparate outcomes and disparate impact. And so I think if we can remember that and actually plan for that, so that the next time if we have a pandemic or the next time we're addressing issues, we can be prepared to pivot our resources to make sure they're applied to the people that need them the most. In many ways, that's the fundamental approach of global health, which is saying, to achieve equity, we have to identify who's the most affected, and we have to put some resources into those who are most effective, and maybe even more resources into those most affected, so that we can get equal outcomes. I hope that, the vulnerability of all of us to what happens to any of us could be a lesson that others can take forward in the interest of advancing global health for the future.
That's a good segue into going back to a discussion about vaccines. How is the Center for Global Health working to help global communities access or even develop COVID vaccines for their own populations?
Yeah, so most of what we're doing at the moment is related to the delivery of the vaccines that we already have available. So we haven't, in our group, been doing as much on the discovery side of vaccines. We do have colleagues who work in that area, but not specifically on the discovery. What I would say is that this in many ways reflects what is often our challenge in global health, which is that we have things that have been discovered and we are trying to deliver them to the places where they're needed the most. So we've been working in particular with our colleagues in Uganda on a program to increase equity about vaccine delivery. And some of that is about getting more vaccines into Uganda and into other African countries in particular. And some of that is about understanding what any barriers might be to vaccine delivery in Uganda, thinking about the gendered impact of vaccination campaigns. In some countries in Africa, amongst those vaccinated, there are more men than women getting vaccines, for example. So the equity work is also about how can we make sure that healthcare workers get vaccinated before, say, private industry or private interests. So working with them is the most specific program we're doing. We've been having, again, my colleague and I wrote an article in summer of 2020 before we actually even had vaccine available about what we would need to do to make sure we had vaccine equity. And of course, it's really only later that really many people are starting to put pressure on this issue. In addition to working specifically in Uganda, we've been working a lot on trying to advocate here in the US, actually, with the Biden administration to try to push for more transfer of technology so that countries in Africa, in Asia, could produce the vaccines themselves. In fact, even on a normal day before COVID-19, 99% of the vaccines used in Africa for routine vaccinations are being imported. And for a continent of 1.2 billion people, it doesn't really make sense that they have to import their vaccines. So I think looking forward, it would be very important. And the African CDC has really called for this to help to establish manufacturing capacity in the country. So a lot of the work we're doing is really also trying to be advocates and be allies for our colleagues in trying to push this agenda forward.
Here's an interesting question, which is, how has technology affected global health in your work?
Well, I'm speaking to you courtesy of Zoom. You know, interestingly enough, when I came to Mass General in 2017, the global health team introduced me to Zoom, and I had not been using that platform before. I'd been using other technology to talk to my colleagues in Haiti and Rwanda and other places, but I'd never used Zoom. So I had a Zoom account before the pandemic. But I think, all joking aside, the video conferencing technology and the improvement in the internet bandwidth in many places has really transformed what we can do. We had a very interesting session with healthcare providers, mostly doctors in Yemen, where there's been a war, where there's a cholera outbreak, they're having a terrible COVID crisis. And a colleague there asked if we could help. Well, we couldn't deploy to Yemen. It didn't seem the most sensible thing to do. But we set up a exchange platform through Zoom where hundreds of Yemeni healthcare providers joined and shared with us at Mass General what they were doing for COVID-19. We found a large number of Arabic-speaking colleagues at MGH who we pulled in to help us to do some work in Yemen. We never could have done that without the technology of communications. The communications technology has also really, in different ways, helped in public health. So in countries like Haiti, where 20 years ago we did not have cell phone coverage, now you have ability to share information on public health, on hand washing, on social distancing through social media, which was never a possibility and is both a huge opportunity, but also a challenge, as we obviously have seen misinformation also spread like wildfire through all the social network channels and create a lot of difficulties for us in public health. Other aspects of technology have been exciting. I actually was at a meeting earlier today at MIT here in Boston about exposure notification on the Google Apple platform, which is a tech issue that I was working on last year, where your cell phone can help in contact tracing and help identify if you've been exposed to COVID-19. And I think there's many other ways. There's some med tech innovations. I don't know if we could put the COVID testing booth into that category, but I certainly might, where we transfer the technology from South Korea to MGH to be able to help us to get testing done safely. So lots of exciting things, and I hope, again, a positive note for the future on where we can take public health through kind of maximizing the innovations in technology.
Well, Dr. Ivers, I think we have time for one more question. This was really a broad-ranging one, but one of our audience members asked, can you talk a bit more about your strategic plan? How would you define and measure success? And what do you hope global health looks like in 2025?
Well, I think what I'd like to see global health at MGH look like in 2025 is really to double the size of our program and to see every department at Mass General Hospital have a global health unit or a global health program that we are helping to spark and support, and that we have a community of practice. I'd like to see global health where we're a platform, where the platform is for this exchange of a really diverse community of scientists, practitioners, trainees around the world, that we're doing our conferences that include them, that we're learning from them, and we're teaching each other. For the world, you know, I mean, I'm a dreamer, call me a dreamer, an optimist. I really think we can have transformative change. I would love to see in the world a global program for health systems into which places like MGH could dock in as part of collective action, so that we wouldn't feel so siloed as an organization that's doing something without clear understanding of what's everyone else doing. I think there's huge possibilities for us. The world is, you know, smaller and smaller. And so our chance to really have a shared impact is very big. So I feel very optimistic about the future of global health at MGH and around the world.
Well, Dr. Ivers, thank you so much. And that concludes our MGH Fund lecture for this evening. We really are grateful for the important work that you and your colleagues are doing in the Center for Global Health, as well as the impact that you're making on the health and actually the futures of our global community members as we respond to the pandemic. I'd also like to thank all of our attendees this evening. I do hope we get to see you all in person and soon, but until then, please be safe out there. Good evening.